Good afternoon, folks, and welcome back to my channel. Today's discussion is one I think is very important. It, it's a topic that applies to a great many women in the United States right now, and it's one where I think the medical profession has let our patients down over the past 2 decades. So, what I would like to get into is perimenopausal and postmenopausal hormone replacement in women. Okay, so let's go into a little bit of the history of HRT, that is hormone replacement therapy, in the United States. When I started medical school in 2000, we were getting told that HRT was almost a veritable fountain of youth for women, that it had numerous proven and suspected benefits. And because of it, almost every woman should be on HRT. So we were talking about benefits for bone density, cardiovascular protection, and potentially even prevention of cancer. Well, in 2002, just as I was entering my clinical externships, everything changed. We had the publication of a study called the Women's Health Initiative, which was a very well-intentioned attempt by the National Institutes of Health to use a randomized controlled trial to get a better sense of what we thought we knew from anecdotal data from doing hormone replacement in women since the 1980s. The results of this study were not what the investigators originally expected, at least in their original assessment of data. Not only did we not see the cardiovascular protection we were anticipating, but they thought they detected an increase in heart attacks and strokes in the population receiving hormone replacement. There was also a highly publicized increase in breast cancer incidence in one of the treatment arms. Initially, this breast cancer increase was almost seen with alarm at the NIH. They held a press conference immediately after the publication of the study, something you almost never see. And in this press conference, they talked about a 24% increase in the incidence of breast cancer in one of the treatment arms. There wasn't any mention of any other data regarding breast cancer. No mention of the fact that despite that increased incidence of breast cancer, we did not see a corresponding increase in breast cancer mortality. Also, no mention of the fact that in another one of the study arms, one that was using estrogen only, we actually saw a decreased incidence and mortality risk with breast cancer. Additionally, they were suspecting there was an increase in cardiovascular risk. As a result, an immediate recommendation went out to all physicians in the United States to immediately cease HRT in the majority of women they were treating. And for those women that did want to continue with hormone replacement because they felt so good on it, we had to have a very frank discussion of the associated risks. The end result of these interventions was that HRT became exceedingly rare in the United States. And we ended up with a whole generation of physicians who were not trained how to prescribe hormones in postmenopausal and perimenopausal women. In my opinion, for reasons we're going to discuss here in just a little bit, this is one of the greatest disservices that the medical profession has done to the residents of the United States. Let's transition from there to what we've learned since the Women's Health Initiative. I did mention that outside the United States, a great deal of research has been done on HRT. Most of this research involves the use of now FDA-approved compounds that are very similar to the hormones that are present in a woman's body. We're talking about estradiol as the primary estrogen and micronized progesterone as the progestin when it's necessary. So random controlled trials of these types of products have shown that there are some very real risks with hormone replacement therapy, but there are also some very impactful benefits. And so any reasonable discussion today about hormone replacement therapy for any woman who's in perimenopause or menopause has to involve this combination risks and benefits and weighing the two against each other. So let's start first talking about what do we know about the risks of hormone replacement therapy? Well, first off, even though there is not a significant cardiovascular disease risk, so no heart attacks or strokes or anything like that associated with HRT, there is a blood clot risk, and that's real. But it's also completely identical to the blood clot risk we see with birth control pills. And we have millions of women on birth control, oral contraceptives around the country and internationally. And while we do see some serious blood clot issues with these products, it's considered a relatively minor thing and not so impactful that it's not worth using oral contraception. So I think the same thing is true of hormone replacement therapy. It is something to be cognizant of, and we have to balance that risk in light of a woman's entire health conditions. Is she a smoker? Is she obese? Does she do a lot of travel where she's going to have to sit for long periods? These are things we at least have to take into account when we're going to be prescribing these kinds of interventions. Okay, next, let's talk about breast cancer. When we have looked at this, we have not seen in these other studies any increase in breast cancer risk. And there actually is some signal, continued signal with women who don't have a uterus where we're able to use estrogen only as a hormone replacement option, that breast cancer risk and mortality is reduced. So, and with the combined estrogen progesterone, there does not seem to be an increase in incidence or mortality with breast cancer. So we're wondering whether or not the signal that was seen in the original Women's Health Initiative was just bad random chance, or was it because these synthetic equine products actually do something a little bit different than estradiol and progesterone when those are used in combination? We don't know. But what we do know is the additional cancer risk seems to be minimal. And we're even seeing physicians who've done extensive research on this now recommending that women who have a personal history of breast cancer or are undergoing treatment for breast cancer currently that does not involve an estrogen blocking action, that for these women, hormone replacement is still appropriate. So that's a long ways to where we were in the Women's Health Initiative. And so those are the primary risks associated with HRT that we talk about now. So let's talk about benefits. Well, the potential benefits of hormone replacement therapy are extensive. What do we see? We see a reduction in the risk of urinary tract infection. We see improved ability for intimacy because a lot of the discomfort with intimacy that comes along with perimenopause and menopause goes away. We see reduced risk of colon cancer. We see greatly improved bone density. As a matter of fact, we've heard of Fosamax and Actonel and all these other medications that are out there to improve bone density. There is no single intervention that we've come up with so far that is better for improving bone density and reducing fracture risk after menopause than estrogen. It's still the best thing we got in our toolbox. Additionally, we see improved mood. We see effective treatment of those unpleasant hot flashes and labile mood episodes that go along with perimenopause. We see resolution of brain fog during perimenopause. We also see improved musculoskeletal health. Menopause itself, we've discovered in recent years, is a big risk increase for frozen shoulder and joint arthropathies. Those risks seem to be mitigated by hormone replacement therapy. Another problem that women suffer after menopause is low libido. Well, by giving testosterone as part of the hormone replacement, we can eliminate that libido problem in a great majority of women we treat. So I think that covers most of the known benefits for hormone replacement therapy. So let's transition from there. So let's talk next about what interventions for hormone replacement therapy should look like. There are numerous FDA-approved products, both estrogens, progesterones, and testosterone out there on the market. There is no FDA-approved product for testosterone replacement in women, but some of the topical products that are approved in men can be used very effectively in women at lower doses. There are numerous estrogen and progesterone products available for women, and they can take a lot of different forms, everything from tablets to creams to patches to suppositories to estrogen rings that could be inserted into the vaginal canal. And each of these could be appropriate for any given woman or inappropriate. There's a lot of trial and error that is involved with finding the right product for a given woman so that she gets the results that she needs. And what this means is when you're looking for a provider to give you hormone replacement therapy, you want somebody who is familiar with, as much as possible, a menu of options. They're not telling you, this is it, this is all I prescribe. And certainly it's not something that should cost you an arm and a leg if you have insurance. Most of these interventions are going to be covered by insurance. There at least should be a good deal of stuff on the option list that is covered by insurance. And even some of those things that aren't, or if you don't have insurance, there are options on the menu that are quite inexpensive, even if you're paying out of pocket for them. Okay, so let's talk about a little bit of what each of these interventions is for. Testosterone, as I mentioned, the primary reason to prescribe it for women would be low libido. It's also something that can be considered if a woman is having recurrent urinary tract infections after menopause and has been replaced with either low dose topical estrogen locally or systemic higher dose estrogen and is not seeing that risk mitigated much. The female urogenital tract has plenty of testosterone receptors in it, and sometimes it requires both for a given woman to get a resolution of that problem. Something else I think women are not so aware of when it comes to testosterone replacement, they're a little gun shy about the idea because they're cognizant of some of these virilization side effects that can occur if they're dosed too high. Well, something we should be aware of, both in the medical community and as patients, is that women during the height of their fertility, during their youth, have more testosterone on board than estrogen. If you look, the units that estrogen is measured in is a much smaller unit than what testosterone is measured in. And the levels that a woman has, if you compare the two, at the highest estrogen peak in her cycle, in her 20s, or even in her teens, when hormones are running rampant, when you see that largest estrogen peak, she's still going to have 10 times as much testosterone in her body as she does estrogen. So we have to consider testosterone as a potential necessity for a woman to feel her best and have maximum mitigation of symptoms after menopause. Oh, okay, so I'm going to talk a little bit more about estrogen and progesterone therapies in that for a woman who is seeking hormone replacement, we have to keep in mind that what we need to do is a little different depending on whether a woman still has her uterus. Many women undergo hysterectomies, and for them, they have the option of doing HRT with estrogen alone. We cannot do that in a woman with an intact uterus because unopposed estrogen in a woman with a uterus will lead to a buildup of the uterine lining, and that can eventually progress to cancer. We can completely remove that risk, though, by giving a progesterone at the same time. And this is a bit significant and complicates the treatment picture a little bit because women respond differently to progesterone depending on who they are. 40 to 50% of peri and postmenopausal women that we give progesterone to are going to feel phenomenal on it. It will actually help them sleep better and reduce anxiety. But is somewhere between 15 to 20% of the population of women that are going to feel considerably worse on it. They're going to feel completely out of sorts. They're going to feel bloated. They're going to be moody. They will not like it. The remainder of the population will tend to, not feel much one way or the other. So for the women with an intact uterus that have that kind of reaction to oral progesterone, we can try using a progesterone suppository or a progesterone cream that skips first pass through the liver, because that does seem to mitigate the side effects for a great number of women. It also may reduce blood clotting risk in women who are prone to blood clots. And the progesterone is the element of both birth control pills and hormone replacement that seems to trigger the increased risk of blood clotting. Okay, so next I'd like to talk about a couple of the myths that are out there regarding treatment of perimenopause and menopausal symptoms. The first of these myths is that if you have gone through menopause and you have not received any treatment and are having problems that may indicate treatment, it's too late. There's nothing you can do. This is absolutely false. It is never too late to start HRT. If you are seeing some of these ongoing problems, recurrent urinary tract infections, intimacy issues, loss of bone density, arthralgias and frozen shoulder, doesn't matter what it is. Even if you are well past menopause, you can definitely seek treatment for these things, and it is not too late. The next myth that has been prevalent since the days before the Women's Health Initiative is that the risks associated with postmenopausal hormone replacement therapy compound as you age. And because of this, we should only treat a woman for, say, 10 years as she starts into menopause, and then we have to stop it because the risk becomes too great. This is also false. We have found that there is no compounding of the risk. And with the risk really being fairly minimal and small in the majority of women, we definitely can continue as long as a woman's alive or some other circumstances change that alters that risk-benefit analysis. As long as that doesn't happen, we can continue. As such, I think it needs to be understood that every woman is a candidate to have a good and thorough risk-benefit discussion for HRT with a healthcare provider that is familiar with the menu of available options for treatment and what the real risks of using those are. That doesn't mean that every woman should be on HRT. It doesn't mean that no women should be on HRT, but every woman should have the option to make an informed decision for herself whether or not she goes on hormone replacement. And I think if every woman had that option, it would not just be a boon for the women of the United States, but it would be an incredible benefit for the men of the United States. The majority of our divorces occur between the ages of 40 and 60. And I think it's not a coincidence that women hit menopause during this time, that the mental health and the intimacy health of women is something that impacts. All right, so I'm going to try and start tying this up there because I think I put out most of the information I wanted to. At this point, I would like to give a shout out to 3 physicians whose online content was essential for me finding the research and information I needed to put this video together. The first of these is Dr. Rachel Rubin, MD. She is a urologist whose practice has a special focus on women's health and is incredibly knowledgeable on these topics and does have her own channel. Go check her out. Additionally, Dr. Vonda Wright, her content provided a lot of the information on musculoskeletal health relating to menopause that I used here. She is an orthopedic surgeon who is focused on health, wellness, and musculoskeletal health as we age. Her content is incredible, and she has a new book coming out in August. I would definitely recommend giving it a read if these are topics that interest you. And finally, Peter Attia, MD, the originator and host of the Drive podcast. I borrowed heavily from his interview with Dr. Rachel Rubin to find some of the research and additional data I needed to put this together. Please go check all three of these physicians out. Their content is superb and I think can be very informative if you want to nerd out a little bit on some important medical topics. Additionally, I am going to include links in the pinned comment for this video for the Menopause Society and for iSwish, an international society focused on women's health and these kind of topics. They can help with their practitioner links for you to find practitioners in your area that can do this sort of medical intervention if you're interested in having that informed discussion about the risks and benefits of hormone replacement therapy. Because finding a practitioner in your area that does this and really does it appropriately and well can be difficult. Unfortunately, we've had a long gap in this country where we were not training physicians how to do this stuff. So with that said, I am going to wrap things up here, and we will see you next time. Thank you. Please remember the contents of this channel are for informational purposes only, and the real intent is to connect you with healthcare practitioners in your area who can give you the kind of care that you're looking for. This channel does not constitute the practice of medicine, and this is not medical advice. Additionally, there is no doctor-patient relationship established by the contents of this channel. Thank you again, and we will see you next time.